Well, I think I'm just going to keep my questions short because I'm sure that the roundtable has a lot of questions, and if possible, we would love to allow opportunity for the audience to ask questions. So I think I'm just going to start with one quick question, and that is to Stacie. And we've heard the expression teach back in a couple of presentations, but I wonder if you could describe that a little bit more for us, especially in the context of health literacy. I think we can figure out what it means, but it would be helpful to kind of have a little bit more dimension on that.
Sure. So really it's engaging the patient around their understanding of their condition, eliciting from them what they understand, asking them, once you've explained to them the medications that they need to take or what they need to do when they leave the hospital, asking them, how would you explain this, for example, to a family member? How would you explain this to somebody? Tell me how you would coach this family member with regards to taking this medication for this condition, and really engaging them daily through the course of their hospitalization until they leave, so that they demonstrate a true understanding of the consequences of not taking the medication or not participating in a particular treatment, and an understanding and able to describe the process by which they should do that.
And so it sounds like, when I first heard it, I thought it would be the nurse gives them information and says, kind of, tell me what I just told you. But I think I like the fact that it is, tell me how you would tell somebody else, because that's a different dynamic. Then they're demonstrating something, but in a different context. Right. Open it to questions for the roundtable. Yes.
Thank you. I'm Winston Wong, and outstanding panel. And for me personally, I'm very proud to be a San Franciscan, very proud to be part of the UCSF community, San Francisco General. I'm proud to be a member of Kaiser Permanente, so thank you for the comments. I thought it was interesting that our two first presenters are physicians, I assume Dr. Pinderhughes and Dr. Lustbader. They talked a lot about the great programs you're doing within your hospital institutions. And Dr. Kinderman to a certain degree as well. But then I think with regards to Reverend Pitts and talking about CTAC and the importance of the community voice and participation. So I want to explore a little bit more in terms of within your hospital institutions, what are the ways that we can more actively engage community in developing the kinds of conversations that have to occur consistently, or whether that's already being done? How do you kind of intentionally orchestrate community at the center of how care needs to be changed with regards to advanced care?
Just want to clarify one thing. There you go. There we go. Sorry about that. Our program is not hospital-based. It's just outpatient and home-based, so we're not at all affiliated with a hospital, which also gives us even more incentive to go out into the community and bring in community volunteers, massage therapists, Reiki therapists. We started also going in to meet with local church groups and temples by doing some education. We have a very large Jewish population in parts of Long Island and have started doing workshops to sort of help the Bikur Holim, the group of folks that like to go and visit sick people, and giving them some new ideas. There's often a concept that the Bikur Holim will go into the hospital to visit sick people, but as more and more care is delivered in the home and outpatient setting, what people really need as they're facing chronic conditions that last a long time, months or a year, is help with dinner, a ride to the doctor. And so we're starting to try to give these community groups more ideas of how they could be helpful, because I believe many of them would like to be helpful, they just don't know how to. And in the past, hospitals have engaged, especially some of these groups, to come in and do some visiting, but more and more people need this sort of help over time at home, especially in support of family caregivers. So we've had some pretty good success over the past 6 months in engaging some of the temples in Long Island to really rally around people that are living alone and home-based, whether they're Jewish or not, but having difficulty getting out of the house.
Yeah, we're just starting to really work with various community programs. We have a senior center in Sun City, we have a very large population of older, old individuals. And so we're really just starting to engage some of these centers that have a number of programs for individuals. They actually will go to the house, pick them up, bring them to the center, engage them in a number of programs that they have. Assists with things like Meals on Wheels. So we're really just at the beginning of starting to, we went through phase one, which was really sort of establishing these programs, and many of our programs, as I said, are in the hospital. We just started a new home-based program. So, you know, we're reaching out, starting with community programs that are already well established.
I would say, I would admit straight up that we do a terrible job of involving patients to plan things. I think that it's a lot more convenient and easier for us to kind of come up with a solution and then impose it on people, and that doesn't work well. And so I think particularly when we're talking about advanced care planning, this idea, especially because it's driven by which box you're going to check around specific treatments, that you have a really hard time conceptualizing down the road if and when that happens. No one is eager to have a conversation around, do you want CPR or a ventilator? But if you turn the conversation around, I think as we've seen examples today around what is most meaningful to you in life, and focus on values and have an understanding of that, I think we do a better job. In San Francisco, the best example I can give is we actually had a community-wide task force on palliative care last summer, and it was really a broad-based group of people from mostly community organizations, somewhat palliative care providers and somewhat hospital-based. You know, there's representation there, but it was mostly advocacy organizations, home care organizations, and other groups, and it was that group of people that I think has the connection with real life in the community, real patients, real families.
I think there are at least two models out there that have been very successful. One model is the model of the Tennessee model, where the hospitals have really gotten navigators from the churches to be involved in the community, and they started the process from the hospitals. Our model at CTAC is that you start from the community, that the community already has networks, they already have groups in the community that are experts in the field, but they have not come together in a unified way, and they have not then worked with hospitals and health plans to really begin to work out ways of really being effective in the community. Many problems come when the community is not only not involved, but the community is not an equal participant. And the Oakland model, which is really tremendously helpful to us, is that the community and the hospitals are equally, and Kaiser in particular, are equal participants in the process. And the engagement is not only an engagement of both, but there is inclusion now in the Oakland area of other groups, such as the University of trying to remember the university, I'm sorry. But there's a university involved in evaluation. UC Davis, involved in evaluation. They do the evaluation. They also have clinicians who are part of the community that are engaged in the relationships. We started looking at two particular problems. One is the clinical really doesn't have a relationship with the community. And so what we did is brought together both the clinical and the community, having a person from the clinical initially who was a pharmacist and a person who was initially a surgeon. So those two were pulled together initially to start the process, and now the process is in the hands of the community, and the community is beginning to develop it and move it in ways that the community feels that it's necessary.
Yes.
Cindy Brock from the Agency for Healthcare Research and Quality. I have a question that I think pertains mostly to Stacie and Dana. I mean, one of the things that we struggle with in delivering the right care at the right time in the right place is the payment. And, you know, traditionally the money has not followed the person, and we've been struggling to put together programs to patchwork together systems of care. You are in situations where you have a health plan or are part of an accountable care organization where you are internalizing certain costs like emergency department visits or hospitalizations that can be diverting the money to be able to pay for the system of care that we want to see around people, wrapped around people. My question to you is whether or not you are, A, being asked to show that the services of your product line are in fact contributing to savings that are offsetting those costs, and B, how we might think about measures of quality for your services, given that as entities that are undertaking the risk, there's an unfortunate financial incentive to potentially stint on care and gatekeep and those sorts of things.
Yeah, it's a great question. So we have a couple of relationships with payers to deliver home-based palliative care with a per member per month rate. And there are several metrics that we are accountable for with that. One of them is admissions per 1,000 members. And I guess part of that is that at least 30% of hospital admissions in our ACO are avoidable or unwanted. Care could be better delivered at home. So for that metric, we're looking at preventing avoidable hospital admissions because most of our patients and their family members don't want to go to the ER at 10 or 11 at night with an 87-year-old and sit in the ER all weekend. So that metric is a quality metric and a cost metric, and they're aligned. The second metric that we are looking at is the location of death is in the preferred location for the patient, which most of the time is at home. And that's where we have concordance on that at over 90%. We are now working on a survey. There does not exist a home-based palliative care survey for people getting active home-based palliative care. So we are developing that right now so that patients in our program can actually take a survey and tell us about their pain and symptom management, quality of life. Caregivers can weigh in on the burden they're facing, and were they surprised by what happened to them over time? Did we do a good enough job preparing them for what to do as their disease progressed? So I think we are at the table with the payers agreeing on the metrics. And I mentioned earlier that one of the payers wanted most in that over 75% of our patients would have a MOLST completed. And we took that out because I didn't feel that was the right metric for the population. We have patients that will be following for years with COPD and heart failure, and the timing would be wrong, the discussion would be wrong. So we took that metric out because we are at the table and we have a voice. And it's really important that people in this room are sitting at the table as the metrics for these arrangements are outlined, because we're the ones doing this work and we know what to measure and what matters. I'll give you an example. One of our payers in a shared savings has a quality metric that everybody discharged from the hospital is brought into the doctor within 30 days. Well, not everybody who goes into the hospital needs to be brought into the doctor's office within 30 days. If they have an appendectomy or a fracture of a bone that's been fixed by the orthopedist, there's little value in calling them within 7 days and having them return to the PCP in 30 days. So we can negotiate on the metrics that actually matter. So perhaps a better metric is for a medically complex person who's discharged, or anyone discharged from a SNF, they're called within 72 hours and they have a touch within 7 days. Risk stratification, post-hospital discharge, and getting the right metric might be what matters. So informing the payer is very helpful.
So we are still trying to work this out with our home-based program. We do look at things like advanced care directive completion rate. So we really are trying to do advanced care planning with our patients. We look at symptoms around opioids and bowel regimens. We look at satisfaction. We also currently take patients that are members of Banner Health Network. So we also were able to negotiate a per member per month rate from Banner Health Network. We look at things like the percentage of our patients that actually transition into hospice and how long they stay on hospice. And that's really where we're focused right now. That probably will change after we get more experience under our belts in the future.
So are you financially accountable, like you're getting a per member per month from elsewhere in the Banner system? So you're doing your own accounting?
Yes.
Got it.
Yes. Mike?
Thank you, Michael Pashorlo. So I'm not a Baptist minister, as it turns out. And so I'm going to break protocol a little bit and ask this question of the ministers, but actually other people might have opinions about this as well. I think it's very interesting to think of a model that I haven't heard this language, but I know of several places that do this, but health ministry. So that hasn't come up specifically. And you know, where I daven, where I pray, if anybody in the group has any problem in any health setting, someone's going to get a call, and their chairman's going to get a call, and then it's going to get fixed. It's going to get fixed fast because we have that kind of access and power in the health system, because there's 30% of the people that go there are doctors. So that's not the case in many places, and maybe health ministry can help solve this problem. So health ministry is a model that I think could be spread not only for access to palliative care and advanced care services, but as a health literacy model. So my question is, can health ministry spread and help serve the cause of health literacy?
Thank you very much for that question. First of all, the vice chair of the, co-chair of the Interfaith and Diversity Working Group is Rabbi Richard Address, who has taught us over and over again that the system within the Jewish community is totally different than any system in terms of palliative care and hospice care in the United States among faith-based groups. And so we're really excited about that model. But in terms of healthcare ministries, most of our churches have healthcare ministries. And most of those healthcare ministries are connected to the models that we are putting in place. As a matter of fact, the structure of most of our Baptist churches in particular is that the health ministries are a service not only the congregations, but they also are in the hospitals, and they also go to work with the sick and shut-ins. There's just a complex system that's developed within particularly the American African Church, both the Baptist AMEs, CMEs, and AMBCs, that's very actively engaged with health ministries. There are some churches who are part of, say, the National Council of Churches that have very structured health ministries and are part of a national health ministry network. They tend to be mainly European American churches that are engaged. Rita Chow is here, and Rita has been a part of a major health ministries network and also been involved in health movements across the country based on health ministries, and also based on nursing ministries, which are a part of that health ministries coalition. So to answer your question, yes, that is, they are totally engaged in many ways. However, when you look at other interfaith groups, such as the Baha'i, such as the African traditional religious groups, their connections are not as great within the health ministries area. They tend to be more integrated within their own faith-based organizations.
So my question is, though, if we can capitalize on health ministry as a vector for health literacy work.
Yes, I think that that's an excellent, yes, some do and some don't. Some do and some don't. Some are more formal, some are less formal. Yes.
So another Baptist minister over the court. I think the challenge is twofold. In my tradition, there's a story called about the Good Samaritan. And I've been doing some teaching on that conversation. In many of our churches, we act like the Good Samaritan, but we forget the part about being transformers so that the Jericho Road doesn't exist anymore. And so we have a dual conversation that's very legitimate going on. In the Jewish community, you have access, you have power, if you will, to make those transformational changes more immediately. And my advocacy in my congregation and the work that I do in my social justice work is that all of our communities of faith must take an active road to A, handle the crisis, but B, also be transformative. And the transformational work goes right to the, I think, to the literacy conversation. Let's do that. And I view that, quite frankly, as a crisis work. But if we transform the system as Bob Arnold talked about, we will actually work our way out of business and won't have to do that because the system will be so doggone different and so transformed that not one patient will not get all the care they need every time they come into a hospital setting and every doctor's office. I'm going to shut up.
I just want to say something about, so I'm a nurse practitioner who practices palliative care, and I have personally had amazing experiences with involving clergy on health literacy issues. We had a family meeting with an African-American family who was really having a hard time making decisions. And one of the issues was whether we should pursue artificial nutrition, which is a very emotional and very value-based conversation. And this pastor spoke about their church's tradition of fasting, something I would have never thought of. And when he put it in that context, the family could come to a better understanding of what would be appropriate in this case. I've seen pastors come. I recently took care of a family who were from the Appalachian area, not educated at all. Their pastor came and helped to kind of interpret, not just from a religious standpoint, but you know, if we were using too technical words, he found a kind way, and because he was so trusted. So I have to say, I mean, as a provider, I'm happy to work with any member of the team, but I am often the one calling the clergy or asking the family, are you part of a faith-based community? Because in many cases, I think they have a credibility and a relationship that we are never going to have. And I think when you talk about discussing life and death, advanced directive decisions, we are the wrong people to be having this. I mean, that if you are a person of faith, you have a community that has a point of view about those things. And I think that is the group that is most appropriate to at least consult, in addition to bringing in other medical, specialists. Yes.
Ernestine Willis, a pediatrician at the Medical College of Wisconsin. Reverend Pitts, I really appreciated your comments, and Reverend Friedman can also speak to this, but there's the historical groundedness of distrust that's throughout many of the under-resourced community, and I call them under-resourced because it could be an urban community of color, but it also could be rural communities, especially when we have gatekeepers who are sometimes controlling the resources that come in and out of those communities. And I do know Amita's community. I also am very much familiar with the faith-based community in Tennessee and how they started their initiative around giving VIP status for people to come into those health systems. But I wanted you to speak to how do you break down some of that distrust, the steps to really help people overcome the distrust and begin to bridge so we can get to health literacy as well as health equity in many of the communities who are most disadvantaged.
That is one of the major foci for CTAC, and we're doing it in 3 ways. The first thing we're doing is we are developing relationships, which we feel is critically important. And that's why Ubuntu is so important for what we are trying to do. When we started the Alameda County work, we were challenged by a foundation who said to us that they wanted to have a meeting of clergy. And so what they did is they opened the yellow pages and they called up churches, called a meeting, and nobody showed up. I mean, that's a relationship issue. And so when we entered Alameda County, we entered with people that we knew who trusted us. And then we built a network of people who were among that community. We also looked at health partners who also the community trusted because of relationships with the community. And so those 2 trust bodies began to have dialogue. And so Alameda County Community Action Project was born. But it's the trust issue, but it's also the communications issue, because one of the other things that we found was that there were some pastors sitting at the table in these institutions, but they were invited in to come in to give general comments, but they were not included in terms of the decision-making process for the institution. So you had people showing up, but they really were not a part of the real process. And we also found that there were people in the institutions who did not look like the people that they were serving. In other words, they were, European American, the folks that they were serving were American, African, Asian, Hispanics, and others, and that there was no disconnect. I mean, there was a disconnect between individuals who looked like them, acted like them, understood their culture and them. And so we began to talk about diversity within the institutional structures, which were ministering to people. And we saw this as a ministry. The health profession is not a service, it's a ministry. And the Jericho Road is a good example of that. But let me finally say this. One of the things that I think is critical at this stage in the evolvement of advanced care is to begin to build relationships, begin to build trust, and for health plans and health institutions to set with clergy and also people at the ground level to begin to dialogue and talk about issues of language, issues of need, and also began to build programs that are mutually beneficial to both. Because in the long run, when this happens, everybody saves money. Now that's a bad word, I shouldn't be talking about that. And some foundations have said, look, we're not interested in money. But the reality is that if you have less people going to the emergency room, and you have better services, and you have more community support, and if you have a transformation of the community, then what you're doing is not only saving money, but you're saving lives. And that's the dilemma that we face as we begin to continue this whole process of developing this whole network of folks. And there are people out there that want to engage. There are health administrators that want to engage. There are pastors and imams and members of the Jewish community and others that want to engage. The question is, do we have the will to do it and the will to work together?
I would just add to that, as well as an African-American clinician, that, we talk a lot about the mistrust that patients have, but in reality, the system has been inherently mistrustworthy to these individuals for years. So there is a history of systemic inequity and lack of access to care, and that's not the problem of the African-American patient or the Latino patient. It's a problem of institutionalized racism and lack in America. So I think we need to kind of flip that around and think about it differently. That is probably as much, if not more, part of the problem. And I think that for clinicians, we need to call that elephant in the room when it's there, when we're in the hospitals engaging patients and we think that there are issues maybe around lack of trust. I always, for one, acknowledge that. I acknowledge the inequities, I acknowledge the lack of fairness, I acknowledge, what has been before, but then also say that, this is where we're at now. I maybe can't fix what happened then, but I can fix what's happening now. I can walk with you and go forward, and I can partner with you, and then I can really align around what your values are. So, I think I just want us to not always go to African-American patients or Latino patients are mistrustful, that they have a reason to be mistrustful, and we still see that today in hospitals.
I cannot help but jump in on that one. Part of the challenge is, and I applaud you speaking in the context as a physician, as an African-American physician, but I'm asking my white colleagues to speak as well. We are the minority in this country, all right? Let's just face that as a matter of fact. And if it doesn't change with white America, it ain't gonna change, y'all. Right. So we do a lot of conversation around the concept of implicit bias. We all come at it with it, all right? We've all been inculcated with certain values and certain mindsets that affect how we deliver medical care. Let's challenge ourselves to, what baggage am I really bringing to the table? Do I see every African-American patient as disadvantaged? Really? You know what, I got some baggage, but I don't think I look disadvantaged. Let's ask those questions very real, and let's be honest with it. That elephant is in the room, and one of the greatest things that happened in Charleston is that the elephant got exposed a little better. Let's talk about it now.